presentation. Today's presentation is on lateral chest X-ray. I'm Dr. K.M. Rizanul Islam presenting today's presentation. As you all know, it is a quite a big topic. So in short, I'll try to present today's presentation. Uh, it will be focused.
Yes, yes.
So you can see the right dome arrowhead arrowhead is seen all the way from front to the back, and note the left dome, that is the arrow, is not identified anteriorly. The outline of both domes posterior to the heart are crisp and clean. The right dome is also crisp and clean anteriorly, as you can see. Next is the most important part, is the hilum. It is said that the hilum is very difficult to delineate properly. Even most experts may find it difficult on the lateral chest X-ray. So if you find it difficult, don't be disheartened. There's a good news. The hilum, normally the position of the hilum is from fifth thoracic vertebra to seventh thoracic vertebra. How we can find out the fifth thoracic vertebra? If you can see the coastal sternoclavicular, the sternal angle, the angle of Lewis, it is actually the opposite the fourth thoracic vertebra. So it is if you write a horizontal line, it will cross the fourth thoracic vertebra. So yeah, from that you can also understand which is the fifth thoracic vertebra. Usual position of the hilum is the it is from fifth thoracic vertebra to seventh thoracic vertebra, and we all know that usually normally the left hilum is a bit higher than the right hilum on the frontal chest X-ray. In the lateral chest X-ray, usually that they actually overlap, so it's not quite easy to differentiate between the right and left hilum. But if you want to see the right hilum, it's better to see from the right lateral view, take the right lateral view, propriotor motion. And if you want to see the left hilum, it's better to take the left lateral view. So here you can see what are the structures. Actually, the main density of the hilum is produced by the pulmonary vessels, namely the pulmonary arteries. Pulmonary veins are not easily seen. The structures in the hilum are the pulmonary vessels and the right and left upper lobe bronchus. Usually, the right upper lobe bronchus is above the left upper lobe bronchus. So you see the trachea shadow. Trachea comes here, and trachea shadow ends there, and there are, and then you can see the two circular shadows. Two circular shadows. These two circular shadows are of right and left upper lobe bronchus, and the right pulmonary artery usually stays in front of the bronchus, and the left pulmonary artery circles above the left principal bronchus. Upper bronchus. So the frontal opacity is by the right pulmonary artery, and the back, the one above and behind is by the left pulmonary artery. You can see the yellow marks here, and the black dots are from the right and left upper lobe bronchus. You can see figure 2.14. The normal chest X-ray to show the location of the main pulmonary arteries is yellow. These arteries account for most of the hilar shadows. Remember, the right main pulmonary artery crosses in front of the right main bronchus, and the left main pulmonary artery hooks over the left main bronchus. Number three is the fissure. The important thing, you know, there are two fissures in the right lung and one fissure in the left lung. The right lung, the fissures are oblique fissure, and the horizontal fissure. In the left lung, the only fissure is the oblique fissure. Again, the oblique fissures almost overlap each other. Not easy to differentiate, but it is said that the left oblique fissure lies a bit rare to the right oblique fissure, but slight rotation of the patient may change the position of the oblique fissures, and the horizontal fissure usually lies at the level from the front, the level of the fourth anterior end of the fourth rib, thoracic rib, fourth rib. Sorry. So at the and the oblique fissures usually said that they here it is shown a bit upper, but actually said that they start from the fifth thoracic vertebra, then it goes behind the hilum and cuts the lower end of the hilum, and then goes anteriorly and cuts the diaphragm about 5 to 6 centimeter behind the sternum. Why it is important to know the position of the fissures? It is not actually always visible clearly with the fissures, but if you understand the position of the fissures, you know that the position of the fissure may change. Like if there is a lesion in the middle loop, like there, if there is a collapse in the middle loop, what will it cause? It will pull the horizontal fissure in, like in the right lung. It will pull the horizontal fissure towards it. So the horizontal fissure will not no longer remain horizontal. It will go downwards, and sorry, uh, it will go downwards and go downwards, almost like this. From from there to here, it will go from there to here, and uh, you understand that the position of the horizontal fissure has come down because of the collapse. Also, if there is an lesion in the upper loop, it can also push the horizontal fissure downwards like this. So the position of the fissure is important. Also, if there is a lesion in the posterior loop, there is a like collapse, then the fissure may go backwards also. So the position of the fissures are very important. Next, we'll talk about postophrenic angles, the rhesus and sulcus. We know we see two postophrenic angles from the anteroposterior view, the right and left postophrenic angles. But remember, this right and left postophrenic angle that we see in frontal axis, these are actually lateral postophrenic angles. These are the lateral postophrenic angles. The postophrenic angles also are made in the posteriorly also, and like here you can see the posterior postophrenic angles. And remember, these are the most dependent parts. Lateral postophrenic angles probably lies at the level of whatever 6 or 7 costal cartilage, but in the posterior postophrenic angles, it lies at the level of 10 to 12 costal cartilage. So these are the most dependent parts. So if there is a mild effusion, it may not be visible in the frontal chest X-ray, but it can be visible in the lateral chest X-ray by on the blunting the posterior postophrenic angles. And it is said that to be visible in the lateral X-ray, only 70 ml of fluid is required. So you can see that in frontal chest X-ray, they said that about 200 to 250 ml of fluid is required to be visible in frontal chest X-ray, and they said the ultrasonography can detect up to 50 ml of fluid, and you see that the lateral chest X-ray you can see anything above 70 ml. So it is almost as sensitive as the ultrasonography to detect minor effusions. So you have to look at these postophrenic angles properly. So another is the lung apex. Important thing is lateral X-rays are not good for seeing the lung apex. Here it is not visible. I will show it in another picture. The lung apex are not good to look at in the lateral X-ray. So if you want to see the lung apex, it is better to see the frontal X-ray, not the lateral X-ray, because the superimposed soft tissue shadows, the lung apexes are mostly opaque in lateral X-ray. So that important thing is that behind the sternum, you will always see that behind the sternum there is a clear space, like clear space. It is called the retrosternal clear space. This space should be clear. That is, this space should be loosened. If you find anything dense here, you know that there is something wrong here. It may be a consolidation, or it may be a collapse, whatever it is, or maybe a mass lesion also. So you have to look for this area, and there is also the line the behind the here it is shown in the first figure 2.17. There is a retrosternal line. So it is actually a soft tissue line. If it is bulging towards interiorly, you know that there is some collection. You see that the second figure it is shown that there is bulging towards the chest. That means there is some collection. It is actually an incidence of root of accident where there is a fracture of the sternum. Now the heart. The heart occupies the middle mediastinum. We know the cardiac chambers from the heart in the lateral X-ray. The front of the heart is formed by the right ventricle. That is shown here by the blue color, and the back just above portion and the back of the heart is formed by the left atrium, which is shown by the green color, and the rest of the back of the heart shadow is formed by the left ventricle, which is shown by the brown color. So the rule is the heart shadow should be homogeneous. If there is any change in the heart shadow, in the homogeneity of the heart shadow, you will understand there is some pathology in the overlying heart, not overlying lung. Most likely the overlying lung, not the heart. So you have to, the heart shadow should be uniform. If there is a change in the density in the heart shadow, you will understand there is some pathology in the lung. Here you can see the great vessels also. You can see the most importantly, you will always see this the shadow of the aortic arch is quite easily visible, and the descending aorta is also visible, because it is important to know, because just below this the hilum will start. You can see the pulmonary artery, the density is the pulmonary artery. Here you can see the black dots, which are the bronchus, the right ventricle and the left ventricle. Now the two bronchial rings, as I have already mentioned, actually, when the trachea ends, we will see apparently the tracheal lucency ends, and then there will be two dots, two black dots. These represent the right and left pulmonary upper lobe bronchus. These here you can see the by two dots. One is the violet color, which represents the right upper lobe bronchus, and the orange color represents the purple color. Actually, the orange color represents brown color represents the left upper lobe bronchus. It's helpful. Sometimes they may not be, both of them may not be visible. Now the bones and the soft tissues. In chest X-ray, you can see the the sternum, the ribs, the vertebral bodies, even the scapula may be visible. One important thing is, I should have said it earlier, or I'll discuss it later on also. The position of the patient. Usually, the patients are positioned in such a way that their arms are lifted above the shoulder, so their arm shadow is not superimposed on the lung shadow, the lateral chest. But if the patient is very frail, he cannot lift his arms. What will happen? There will the shadow of the arms and the scapula will be superimposed on the upper part of the chest. It may look like there is a mass lesion or something else. So how will you differentiate? You will have to look for the humerus. You will see that both the humerus is there on the chest, lateral chest X-ray. If you find there is the humeral shadow is there, you will understand that the shadow in the upper lobe is actually due to the soft tissue of the hands, and these are not pathological. Now again, in case of the vertebral bodies, you have to remember the vertebral bodies are actually rectangular, and these are actually, each of the vertebral body looks similar, and their anterior and posterior end should be parallel and the similar length. If there is a disproportion in the lengths, you will understand that there is some pathology in the vertebral bodies. Also, the general rule is from above to downwards, the vertebral lucency will increase. That means the upper thoracic vertebrae will be opaque, and the lower thoracic vertebrae will be more lucent because of the presence of the more soft tissue in the upper part of the chest. If you find that the lower vertebral bodies are also radio opaque, then you have to understand that there is some pathology in the lower lobe of the lungs. Also, if you see that the lucency in the upper lobe, upper part of the vertebral bodies are also like the lower part, then you can understand this is related to osteopenia. Normal chest X-ray, here you see that the lower vertebral bodies are blacker. You can see because of there is less soft tissue and the no scapula superimposed. Consequently, there is less absorption of the chest X-ray beam inferiorly. thus more blackening of the radiogram. Whiteness inferiorly on the chest X-ray invariably indicates pathology like collapse, consolidation, lung mass, and paravertebral mass. Also, note the assessment of the lung apex is very difficult, usually impossible. So, normal adult chest X-ray, there are some pitfalls. One pitfall is that if you look at this X-ray, it looks like here is a mass lesion or something. It is actually not a mass lesion, it is actually the heart shadow. That at times they said that the right rim of the diaphragm may be elevated so much that it may coincide with the posterior border of the heart, and it may look like a mass lesion, but it is not a mass lesion. I think it is not quite common, so I think we don't need to have too much headache about this. And number two is the unfolding of the aorta. You have to keep in mind about of the age of the patient. You see that if it is a young patient, the ascending aorta, the aorta and descending aorta, there lies posteriorly in the mediastinum, so there does not produce any other shadows. But as the age increases, we go through middle age and later on the aorta unfolds, and by the left lung, the anterior border and the posterior margin of the aorta produce a different shadow. You can see here the unfolding of the aorta is producing a different shadow. As the age increases, the unfolding will be more prominent. So, in the lateral X-ray, they may produce a tubular shadow. You have to remember it is the aortic shadow, it's not a pathological shadow. So, you can see in the figure 2.32, this showing that the normal chest X-ray is 20 to 40. The mid and distal part of the descending aorta is not visible. And on the 2.3 figure is 80 years. You can see that the age-related aortic unfolding occurs in the middle age and in the lip. The descending aorta is outlined by the lung and is visible by the arrows. You can see the arrows here. This is the same patient, like the other patient in 2.31. You can see here in the 2.31. And another most important thing that I actually missed, we can at times, it is the most important one actually. You know that the left heart, its apex and its epicardial fat, it may compress the left lung anteriorly and inframedially. So it may looks like there is a collapse or mass lesion in the left lung. It is actually not. Here you can see that there is a rapid upside as marked by the arrows. So you can think that probably there is a collapse or mass lesion, something is there. It is not actually. It is normal. It is called the cardiac incisor. The anterior density shown by the arrow is caused by the normal cardiac apex and epicardial fat, displacing the most inframedial and the adjacent aspect of the left lung. The shape of the cardiac incisor will show considerable variation between patients. So you have to keep it in mind. Incidentally, a cardiac incisor shadow with here it is see with a somewhat different contour is also seen in another picture. We have 10 minutes more. So we are almost closing in. The lateral X-ray, what are the 6 points we have to see? The 6 points checklist. Number 1, are the vertebral bodies becoming blacker from above downwards? If not, they are becoming whiter, then the suspect the disease is in lower lobe. You can see in the number 1 is the normal one. You can see the vertebral bodies are becoming blacker as we are going downwards. In the next figure, it is 2.33. You can see that the vertebral bodies suddenly become whiter. So what is it? The patient actually presented with cough and fever, vertebra white inferiorly. What does it indicate? The outline of the left dome of the diaphragm is absent posteriorly. The left dome of the diaphragm is not visible posteriorly. Why? Because the left lower lobe, there is a left lower lobe pneumonia. Because lower lobe pneumonia, the lungs lobe almost it is mixed with the diaphragm, so it is not able to discriminate between them, and the vertebral bodies has become whiter in the lower area. So always look from above downwards of the vertebra. It can happen in collapse also, lower lobe collapse also. And are the both domes of the diaphragm well defined and clearly seen? We have already seen one thing in the previous figure. If either dome is obscured, suspect disease in the adjacent lower lobe. As we have seen in the previous one, as the previous one, the left dome was obscured, so we can think that the problem is in the left lung, lower lobe. Here also, If either dome is obscured, suspect that is in the adjacent lower lobe. You can see in 2.37 here, or you can see the patient was presented with unwellness, fever, and chest pain, vertebra wide inferiorly, and you can see the outline of the right dome of the diaphragm is absent posteriorly, right lower lobe pneumonia. Uh, Remember, the right dome should be visible from front to back. So the right dome, we already have said, the right dome should be visible from front to back. Normally, the anterior aspect of the left dome disappears. So you have to keep it in mind when differentiating between the right and left dome. You can see the figure 2.38, what you can see here. The persistent cough and hemoptysis, the lower vertebra are white, as you can see here, than those of the above. Shadow of the left dome of the diaphragm is absent. It is not quite easily seen due to the photograph is not clear. So, the straight line of the oblique feature is displaced posteriorly. You can see that the oblique feature is displaced posteriorly. It has become posteriorly, gone posteriorly. So it is the collapse of the left lower lobe. It is actually due to bronchial carcinoma. Number 3 is are the hyla normal? Two questions to be asked. Does the overlapping or the combination of shadow of the two hyla appear enlarged? Number 1. Number 2 is the outline of the overlapping hyla well defined, like normal vessels, or do the borders appear anarchic and irregular or lumpy bump? That means if the hilum here you can see the hilum is not clear, number 1, and also it seems a bit lobular, or they have wanted to say irregular shape. If the hilar shadows are enlarged and irregular, you have to think this is due to lymphadenopathy. Also, it may look like enlarged, but due to the enlarged pulmonary vessels, but in that case, there will be parallel shadow. You will see the parallel shadow, and the hilum will not be the bronchus will be easily visible. Also, you have to compare with the frontal chest X-ray. If you see the frontal chest X-ray and then compare with the lateral chest X-ray, it will be helpful to differentiate whether the hilar shadow is due to lymphadenopathy, or due to enlarged vessels, or due to mass lesion of substance. We may discuss about it later on if we have time. Number 4 is there any abrupt change in density across the cardiac shadow? I have already said this is if it is seen that this is likely to be a lung abrupt. Here you can see it is the retrosternal clear space, but if you look in the heart, what do you see? That this part is quite loosened, but this part is opaque, more opaque. So there is something there. There is something there. You can see the horizontal fission and lateral fission. So it most likely represents the middle lobe. So you can see the abrupt change in the density over the cardiac shadow. That means middle lobe pneumonia with slight loss of the volume. So there is slight loss of the volume, as you can see. Number 4 is 5 is are there any abnormal lung densities? It may have to check the superimposed over the heart, behind the heart, or posteriorly in the costophrenic places. If it is in the costophrenic places, that is most likely due to effusion. Here you can see that there is a shadow which is not visible in the frontal chest X-ray. This patient presented with hemoptysis in a middle-aged smoker. Frontal chest X-ray was unremarkable. Note the solitary pulmonary nodule projected over the heart. It later proved to be a bronchial carcinoma case. And number 6, not the least, always could relate the findings with the frontal chest X-ray. So we, in the normal rule, we always ask the patient to do a frontal chest X-ray. Then, if we have suspicions, to be more clear, we have to go for a lateral chest X-ray. The most important thing is with the advance of chest CT scan, the art of lateral chest X-ray is almost forgotten. There's the problem. If you do not see a lot of lateral chest X-ray, it is always difficult to understand the pathology of lateral chest X-ray. So in a resource constant country like us, we have to have still have some expertise on the lateral chest X-rays. So I will conclude here. I have some X-rays later on. If we have time, I may show you. You may say what are the abnormalities there. Now you can ask me anything if you want.